Welcome to this video presentation on induction of labor. This presentation was created by a team of physicians and nurses at the IWK. It will take approximately 10 minutes. There is a short survey at the end of this presentation and we would appreciate your feedback. The goal of this video is to provide you and your support people with information on induction of labor. We will give an overview of what to expect at your appointment when induction is discussed. We will review common reasons for induction and the steps of induction and discuss the associated risks. We will end with some answers to common questions. At your appointment to discuss induction of labor, you can expect to have your health and pregnancy history reviewed. Your baby's heart rate will also be assessed. To plan for an induction, we'll also recommend that you have a cervical exam done during the appointment. Your cervical exam can provide important information on how an induction can be accomplished. Finally, your appointment will conclude with a discussion around the rationale for induction of labor. This will include talking about the risks and benefits. Listed here are some of the common reasons induction of labor is recommended. We will be reviewing each of these on the following slides. Once a pregnancy is longer than 41 weeks or 10 days past your due date, we call this post-dates. There are risks associated with pregnancies that continue past this length of time, and for this reason we recommend induction of labor and/or increased monitoring for baby's well-being. Rupture of membranes is also known as your water breaking. When your water breaks but labor has not started on its own, we recommend induction of labor as soon as possible if you are Group B strep or GBS positive. If you are Group B strep negative, we will review waiting up to 24 hours prior to starting your induction. There are several other reasons we recommend induction of labor. For example, we recommend induction of labor for patients with diabetes, high blood pressure or preeclampsia, older age, pregnancies conceived with IVF, or other medical conditions. There are also reasons related to baby that we may recommend an induction of labor. For example, we may recommend induction of labor when we have concerns about the baby's heart rate or if there is too little amniotic fluid around the baby. We also discuss induction when baby size is smaller or bigger than expected. Finally, we also recommend induction of labor in some twin pregnancies. We are going to briefly review some important anatomy. The uterus is where your baby develops throughout your pregnancy. The uterus is designed to stretch and allow your baby to grow. The cervix is the opening between the uterus and vagina, and it stays closed throughout the pregnancy. During labor, the cervix will change shape to allow the baby to pass through. There are two steps to an induction. The first step is to prepare the cervix for labor. The second step is to start uterine contractions. It is important to note that if the cervix is already favorable, thin, dilated, and soft, then we can go directly to step 2. The goal of this first step is to soften, thin, and dilate the cervix to prepare it for labor. There are 3 options for this step. One is mechanical with a balloon catheter, and the other 2 involve a medication with hormone. One option involves placing a Foley catheter. This method involves placing a thin tube or catheter with a small balloon at the end past the cervix so it sits between the baby's head and the cervix. The balloon is then inflated with a small amount of water. This places mechanical pressure on the cervix, causing it to soften and open. It involves a small procedure to place the catheter and is very similar to a Pap test. It may cause some cramping once inserted, but this tends to settle with time. The catheter is then taped to your leg. You are still able to walk and use the bathroom normally. This method of induction is usually done on the birth unit, and we often recommend starting oxytocin, part of step 2, at the same time to get the uterus to start to contract. Once the cervix is around 3 centimeters dilated, the balloon catheter will fall out on its own. Options 2 and 3 involve a hormone called prostaglandin. This is a hormone produced by the body that softens, dilates, and thins the cervix. It can also cause uterine contractions. It is important to note that these options are not recommended in patients with a previous cesarean section. There are two forms of this hormone that we use at the IWK. The first option is called Cervidil. This is a medication placed in the vagina that has a tampon-like string attached so that it can be easily removed. It releases this hormone over 12 to 24 hours. This option is done as an outpatient. Once the first Cervidil is placed, you will be monitored for an hour, then plans will be made for you to return to the obstetrics day unit in 24 hours to have your cervix reassessed. If your cervix has not changed, you may need more doses of this medication. The third option is a pill called misoprostol that you swallow. This is done as an inpatient, meaning you will be admitted to the hospital. This medication is given every 4 hours, and most patients require 3 to 5 doses for it to be effective. Deciding on the type of cervical ripening is a common question we get asked by patients. There is no right or wrong way to proceed with cervical ripening. Some people like the idea of having the catheter placed and the oxytocin started right away. Others like a more gradual approach and would prefer to take a medication by mouth rather than in the vagina. Some patients have tried one method in a previous pregnancy and were happy with this. However, others may feel that they want to try something different in this pregnancy. An advantage of the balloon catheter is that it is effective in preparing the cervix for labor. It is also the fastest method of induction from the start of the process to birth of the baby. It is the only safe option to prepare the cervix or labor in patients who have had a previous cesarean section. A downside of the balloon catheter is that it involves a minor procedure to have the catheter placed. The procedure is similar to a Pap test and done in a birth unit room. The catheter can also cause some cramping after being placed, although this usually settles fairly quickly. Finally, it is not an option for patients if the cervix is completely closed or if your water is broken. Cervidil is an effective method to prepare the cervix for labor. Because it can be done in an outpatient setting, you can go home in between doses. Doses are usually 24 hours apart. One disadvantage is that patients often need more than one dose, which means the cervical ripening process can take between 1 to 3 days. Misoprostol is an effective method to prepare the cervix for labor. It is also a pill that can be taken by mouth, and generally no cervical exams are required in between doses. However, misoprostol usually takes 3 to 5 doses before it has an effect, or 12 to 20 hours before the cervix starts to change. You will also need to be admitted to the hospital to receive this medication. Once the cervix has started to change for labor, we move on to step 2. In this part, we use 2 methods to get the uterus to start to contract. The first method is called artificial rupture of membrane, or breaking the sac of fluid around the baby, and the second method is a medication called oxytocin. We generally utilize both of these methods at the same time. Once the cervix is favorable, usually 2 to 3 centimeters dilated, and the baby's head is against the cervix, the membranes can be ruptured. The amniotic fluid contains prostaglandins, a hormone, that help with cervical ripening and contractions. This exam is similar to a cervical check, however, we also use a plastic hook to gently open the amniotic sac. This will not cause pain to your baby. Once the sac is broken, fluid will continue to leak until delivery. Oxytocin, also called Pitocin, is a hormone produced by the body that causes the uterus to contract. It is given through an IV to start or to increase contractions. We start at a low dose and then gradually increase it until contractions are strong and close together. We recommend continuous monitoring for patients and baby. There are some risks associated with induction of labor. The first is that your uterus may start to contract too much. This can sometimes stress the baby, leading to changes in their heart rate. If this happens, your care provider will remove or stop the medication that is causing the uterus to contract too much. Next, oxytocin can increase the risk of bleeding after birth. Induction may also increase the risk of requiring a cesarean section in labor. There is also the possibility that the induction does not work and you do not go into labor. If this occurs, you will have a discussion with your care provider about alternative options, including a different method of induction, waiting and restarting the induction after a break, or rarely proceeding with a cesarean section. There is a risk of uterine rupture, which means tearing of the uterus. This risk is very low in patients with no prior history of a cesarean section. However, in patients with a history of a previous cesarean section or major uterine surgery, this risk is less than 1% with induction. Finally, when the membranes are broken for a long period of time, this can increase the risk of infection. You and your baby will be monitored for signs of infection, and if there is concern, an antibiotic might be recommended. The baby will also be assessed for infection after birth. While labor is a natural process that your body is designed for, in some pregnancies there are reasons that it might be safer to start labor so that your baby can be born sooner. These reasons could be for your health or the health of your baby, as we reviewed earlier. The risks of induction of labor must be balanced with the risks associated with continuing the pregnancy. This will be reviewed with you at your appointment. Inductions can take 1 to 3 days depending on how labor is induced. Some of this time can be spent at home, but depends on the method of induction. There are other ways to try and encourage labor to start on its own. One option is called the membrane sweep. This can be done by a healthcare provider. During a cervical check, the doctor uses one finger to separate the cervix from the fluid-filled sac around the baby. This releases prostaglandins and can sometimes encourage labor to start on its own. Listed here are some resources available through the IWK, as well as commonly used phone numbers, including the Early Labor Assessment and the Birth Unit. Thank you for watching our video.